Well, thank you so much for having me, and I'm so sort of the lowest on the totem pole in this amazing group, but I did have my slides match my suit, which I must say is quite a tour. So I don't have any conflicts, unfortunately, and if anyone wants to give me some, I'd be happy to take some afterwards. As far as the background goes, as you've heard already, I'm going to give you the Fellowship Council sort of background of where we are and where we would hope to go, and we need your help. Everyone in this room is somebody that is instrumental with fellowship training or is an interest in fellowship training. So what do we do for assessments now? We do quarterly assessments, which are both technical and clinical, and as Rory mentioned, please, if you're not doing them, do them. And have many of your faculty do them too. And you may have your own assessments too. Many people have their own biannual in-person debrief with their fellows. We're hoping that you're doing more than that, obviously, as has been mentioned after every case, etc. And then many do tag to their internal evaluations for the residency, and this is sometimes helpful as far as feedback goes because it can be lumped into a greater bucket of feedback from residents and fellows in order to de-identify things. One thing that is coming up is that we do have a major IT overhaul, and many of the speakers today are involved in that. And one of the key things to think about, one of the easiest ways for me to understand this, is everything that we receive right now through our Fellowship Council website is basically text. It's not really data elements. And so we're changing this to really be more of a database, data element type of format. And it's really going to try to make everything more understandable. I won't get too much into this except to speak to you about the assessment piece. And Leanne, thankfully, is heading up this and I think will be really important. So what do we know about assessment? We know that a few data points are the worst way to assess somebody. We need several data points, preferably many, many data points. And we also know that faculty really suck at using the Likert scale, right? They either want to go straight in the middle, or they want to be everyone's friend and be a number 5 for everyone, etc. And so those of you that are program directors or fellowship directors know that when it comes time to honest feedback, we don't have much to go on, right? Everyone knows that this resident's really terrible, but there's no evaluations to support that. So what do? We have 4 data points and we use a Likert scale, right? The worst possible thing we could do. So we're trying to change that. So what would the new structure look like? Well, we would like to break this up into 2 global areas, technical and clinical. And we really do want to hone down on not only the video assessment of technical ability, but also judgment, ability, etc. And what we're doing from the technical standpoint, which probably is a little bit easier, again, we have a lot of great expertise in this group, is to choose potentially 2 index cases for each fellowship type. So you already know this from the technical tool that we have, but for example, for HPB, sort of my world is, Whipple liver resection. MIS may be something like a Heller or Nissen. Again, this is up to the sponsoring societies of the Fellowship Council. For bariatric, potentially something like Rohan gastric bypass or sleep. These are just suggestions, but these would be things that potentially could be used. We then would want several opportunities to assess those technical areas. And you have to understand, it's not like, just to step back for a minute, when I went into the lab in 1991, the thing I learned more was how to set up controls. And I'm sorry, but we suck at controls, right? Because we started antibiotics and the patients got better, so it must have been the antibiotics. We don't have that control, which was the no antibiotic arm, right? So I spent the first 6 months looking at blank gels because my PCR machine was not cycling, but I didn't realize that. And I could not understand that my control was another PCR machine, right? I mean, I just couldn't get my mind around that. But we have several permutations here, right? Because nothing is controllable. We have a faculty who may or may not have had an argument with their spouse that day, who may or may not have gone to work out that day or missed their class and had to pay $12 for Orange Theory, or may not have, had a bad day benching, etc. With the case type, right? This is a different patient, so it may be that gastric bypass in a 35.01 BMI, or it may be a 55 BMI patient where your mindset is different. It's a case complexity. So my surgical first assistant, who helps us with some of our cases, says, I'm glad you booked the hump case first. And I was like, what? He goes, you always have a hump case. This is the case where you're the most stressed, and I know I've got to get you through this before you can relax for the rest of the day. And so it's the redo liver, or the redo Whipple, like does that really happen? Yes, it does. Or the, some disaster case that's booked in the bunch of 5 cases, and so he always says that's your hump case. You're in a better mood after that case. And so we all have that, right? So let's talk about an example of pie in sky where we may end up. So case finishes like a Whipple. Fellow logs the case because we have to have that logged. It generates an evaluation tool where the fellow evaluates the faculty. So yes, faculty, you're going to be at risk too because we're going to talk about autonomy. The faculty evaluates the fellow. Well, I would love Leanne to think about, how about the other people in the room? What did the scrubs see? It may just be a quick, yes, who did the case? Fellow attending. What did the anesthesiologists see? Were there moments in the case that sounded scary to them? What did the circulators see? Just thoughts. But I think, again, a more 360 global evaluation would be really interesting. So what would the assessment tool be? And Leanne is working on this. For others, as I said, who did the majority of the case? It could be a binary answer, but we'd love to see that shift during the year. And it's like ERAS, right? Those of you that have rolled out ERAS, if you don't measure it, it doesn't get better. We're going to be pushing you as educators to be better educators too, especially in the area of autonomy, independence, etc. Who was on the right side? To speak to my thing, we've done some work on perception of fellows and faculty, and there's a real disconnect over there. I thought I was doing every case as a resident, and I was boving on a right angle, and I thought, my gosh, a monkey could do this. But I thought I was doing the Whipple. I was like, really, I was like, I can do this. And so the first thing I do for our fellows is, you've got the right angle, I've got the bovie, you do whatever. And they look at me like, I've never done this, I've only done a few Whipples. I'm like, it's okay. I should be able to get you through anything here. Who transected the pancreas, who handled the cautery, at a famous institution, faculty still sews the pancreatic jejunectomy throughout half of the year for the fellows. So these are things we have to measure. And what we're going to do then is, we are going to then hopefully have a little feedback tool where you will see where you stand in each of these domains compared to the rest of the fellowships. Boy, the one thing I know is that we're really competitive, right? And if our fellow is not doing the pancreatic OJEG at 3 months into fellowship, and every other fellowship is doing that, there's going to be a change in the way I practice. So this assessment tool is going to help us all. Leanne, you've got a big task. So we would like to look at clinical evaluation too, right? Look at EPAs and how they fit into this. So for example, for HPB, is that can this fellow evaluate a pancreatic mass effectively and independently? MIS, some examples over here. Bariatrics, same deal. And the example here might be, and again, we haven't worked this out as well because it's a little bit more difficult, and it'll fit into the EPA framework a little bit more, but evaluate the patient with the pancreatic mass, log a case, because I would like to think about, we're not there, but think about non-operative assessment as well as operative assessment. Generate an evaluation tool. Again, faculty evaluates fellow evaluates faculty, but then the question is, would there be a scenario where the patient might be able to tell us what they think, or where the MA or the nurse might think, wow, this fellow is somebody I'm comfortable taking the next set of orders from, etc. So how would video assessment fit into this? And again, it's going to be easiest in the technical arena, right? We use index cases as prescribed. Right now, we have a placeholder for this. So we are ready to populate that once our IT overhaul runs out, but we have a placeholder. And what I mean by that is, data-wise, I've made sure that our IT people know that there needs to be a server somewhere in that magic space, the cloud, that will hold it. So how would video assessment work? So the challenges here are going to be edited or unedited, right? We all don't want to go through 18 hours of video. But who edits this? Because things can look really different depending on editing. what is the key portion of the case? So each of our sponsoring societies needs to help us, right? Is it the sewing of the gastrojejunostomy and the gastric bypass? Is it the placement of the stapler? As we were watching those videos that we just saw, it was very interesting because the way that that stapler went in was so different in each case. I would also say, just feedback for our group, it's also when to slow down, right? Because we each have key portions of our case where we need to slow down because they're critical portions. Open versus MIS. It's certainly easier to record an MIS case. The GoPro doesn't look so well on my hair. Who would evaluate? Would this be an independent evaluation process? Technical experts in their field? What do we assess? Is it safety, dexterity, slowing down at the right time, overall sense of the video? And then remember, this is fellow dependent, right? And I really want to make sure everyone here understands that the Fellowship Council, we are the Fellowship Council here today, doesn't certify fellows, we accredit programs. So we're talking about videoing fellows. Really, should we be videoing their faculty to assess competency to teach? So I just bring up these things because it may not be the right place for fellow-related assessment to specifically fit into accreditation. But maybe what we could do is collect and send to the societies who then certify the fellows. But I do think there's utility to assessing the program with regard to the faculty teaching ability. So these are just things that have been that I thought about. And so in summary, there's lots to plan. The video assessment is still to come, but this is why we wanted to talk about this today, because we're in the inception phase. We want to know what you think so that we can build it as you all see fit. Thank you so much.